In clinical practice, a patient with highly variable lab values is often described as unstable. A patient with smooth, consistent readings is described as stable. But variability and clinical risk are not the same thing. Variability measures how much a biomarker fluctuates around its central value. Clinical risk measures how close the patient's trajectory is to an irreversible threshold. A patient with noisy but safe readings is not at high risk. A patient with smooth readings on a declining trajectory may be approaching organ failure. These are structurally different clinical situations. Clinical variability measures the spread of biomarker values around a reference range. An elevated reading and an equivalent reduction contribute identically to measured variability. The measure is symmetric. It has no concept of direction. It does not register whether successive readings are drifting toward a critical threshold. Variability measures dispersion. It carries no information about trajectory. A patient fluctuating widely within safe limits and a patient declining steadily can have identical variability scores. Clinical risk is defined by proximity to an irreversible physiological threshold. Organ failure, hemorrhagic stroke, and circulatory collapse are absorbing states. Once the patient crosses into that territory, the clinical trajectory changes permanently. This structure is asymmetric. Only the crossing into the irreversible zone matters. A biomarker moving toward that threshold carries risk regardless of how smoothly it moves. Direction and distance from the threshold determine exposure. Spread around the mean does not. A patient can show highly variable lab values while remaining structurally safe. If the readings fluctuate widely but consistently stay within a normal range, far from critical thresholds, clinical risk is low. The variability is real. The spread is large. But each oscillation remains far from the level at which irreversible deterioration begins. Distance from the absorbing threshold is the relevant clinical quantity, not the magnitude of fluctuation. Consider a patient whose biomarker values barely change from reading to reading. Variability is near zero. The numbers appear stable, even reassuring. But if the trajectory drifts steadily toward an organ failure threshold, the outcome is predetermined. This pattern appears in patients with gradual septic deterioration or slow hemorrhage. The apparent calm of low variability masked an adverse trajectory. Clinical risk scores based primarily on variability fail to detect this class of deterioration. Early warning systems that score primarily on variability miss trajectory-based deterioration. National early warning scores and similar tools aggregate point-in-time values. They measure how far readings deviate from a reference range, but they do not measure drift toward an absorbing threshold. A patient with low variability and adverse drift can score as low risk until moments before collapse. To detect trajectory-based risk, clinical monitoring must track direction and distance. Variability is a dispersion measure. It is not a trajectory measure.